Hi everyone, today I'm gonna presenting the sexuality and aging. So this lecture is kind of long, please bear with me, and we're gonna go over this topic from different aspect of the sexuality and learn how it gonna affects the older adults. So this is my learning objective outline, and then after this lecture, you're gonna able to discuss the effects of the societal attitude toward the sex, and then older adults explain the effects of aging and on sexuality and sexual function, identify the measure to manage menopausal, andropausal symptoms, describe the factors that can contribute to the sexual dysfunction. Also, we're gonna discuss some nursing care after we learning of the intervention risk factor, and then we're gonna promote the healthy sexual functioning in older adults. Lastly, I included a reference that I used in the lecture slides. So if you're interested, you can click on that at the end. So let's get started. We're gonna begin with the sexuality dimensions, and then we're gonna go over the rest of them, the risk factors, and then go to the nursing consideration. Okay, so sexuality. This is influenced by the interaction of biological, psychological, social, and individual factors. And based on the World Health Organization, there are four major dimensions of the sexuality in public health to provide the foundation for addressing sexual health holistically in all stages of life. And first, we having the sexual health. This is a lifelong state of the physical, emotional, mental, social wellness related to the sexuality, not just the absence of the disease. So it focuses on of safety, constant physical well-being, such as safe sexual experiences, like accessing to the sexual health services, having an STI testing done, contraception method, and sexual education and informed decision making also included. And the goal is to ensure that individual can engage in sexual activity safely, um, with the respect. So next we having the sexual well-being. This this one goes beyond the health. It emphasizes the satisfaction, self-esteem, and comfort with the one's sexuality. It is focused on the emotional and psychological fulfillment, like emotional intimacy and then satisfaction. So the goal is to promote the happiness, confidence, and overall quality of life throughout the healthy sexual experience expression. And we having sexual pleasure. This one involves physical and emotional gratification that came from the sexual activity, such as arousal, intercourse, and it's gonna focus on the enjoyment and satisfaction as well. So the goal is to value the pleasure as a natural and important part of the human sexuality that supports the emotional and relational well-being. And lastly, we having sexual justice. This is a fair recognition gonna protect everyone's sexual rights and freedom regardless of the gender, orientation, or identification. So it focuses on the equity, rights, freedom from the discrimination. So the goal is to ensure that all the individuals can express the sexuality freely, safely, with dignity, and inclusive society. So the sexuality of older adults is shaped by a complex interplay of all the factors. Um, on the next few slides, we're gonna go over each of the risk factors, and then talk about how it affects those four sexuality dimensions. So first one, we having the challenge number one. This is based on the socio-cultural dimension of the sexuality. So in our geriatric book, back to the last century, the people had limited access to the information about sexual health, and teaching or talking about sex was considered shameful and sinful in different cultures and also countries. So people was changing the attitudes about this topic over time, and society had become more open and educated about sexuality, which is a good thing. And Not only we can see the media, books, counseling help the people to learn the sex as a natural, healthy, also the normal, beautiful human experiences. Um, However, sexual health among older adults has been viewed as a taboo topic or dismissed as a non-essential lifestyle issue that falls outside the traditional focus of the medical care. Um, for example, during this time, the double standard exists between the young people and the elderly people. And when the elderly adults express the sexual interest, society often respond with the judgment rather than understanding. Um, some, um, for example, 30 years old man may be labeled as a playboy, but 70 years old man showing the same interest gonna call the 30 old man. Likewise, the older men who date or express the desire are frequently labeled um as mocked or shamed, while the young individuals are rarely criticized for the same behavior. So when we're talking about the sexual behavior and roles, the aging doesn't erase the sexual identity or desires, and the older adults still remain capable of sexual enjoyment. Also, general patterns of the sexual behavior is basically consistent throughout life. For instance, someone who enjoys active sex earlier usually stays stable the same when they're getting old. But for someone who wasn't interested before, is gonna rarely develop the strong new desires when they're getting old. And sexual expressions like homosexuality, masturbation, or other preferences will still remaining the same as part of the person's lifelong identity. On the other hand, the perception of the gender sexual roles having evolved over time. Uh, for example, the women, um, hold on. As an example, the traditional expectation from the man was supposed to be strong and independent, and the women supposed to be gentle and dependent, like caring for the baby more. But when the women's liberation movement reshaped these norms and in promoting the equity and shared responsibility between the genders, but in the real life, the nurses and the caregivers often ignore or disrespect the older adults' sexuality. Um, for instance, in the skill facility, some of the staff usually ignoring the grooming requests, dressing all the nursing home residents in the same asexual clothes, and exposing the patient during the care, making the jokes about elderly couples who are the same-sex partners and forgetting that older adults also having the same need for privacy and also the self-expression as the young people. But in fact, the age doesn't erase the sexual identity because everyone deserves the dignity, respect, privacy, so we should treat 70 years old patient with the same sensitivity as 20 years old. And then let's talk about the increasing risk factor of sexual transmitted infection in older adults. I'm I put on this slide because this is the important thing uh, from my perspective, like the baby boomer distributions. So based on the research, there's a increased life expectancy and aging, which had led to a great impact in the older adult population. As you can see on this slide, in 2021, rep the research has been reported that approximately 50.7 million Americans over age 65 and older, representing the 17% of the total population. So by the 2050, this number gonna projected to increase to 83.7 million individuals. And globally, the population of the adults aged 65 and older is expected to be reach 1.6 billion by the 2050. And you may be wondering how this number impact the sexual health, and then I'm gonna explain the reason very soon. So, sexual risk-taking among older adults has become emerging public health concerns, primarily due to the rising incidence of the sexuality transmitted infections, including the HIV or the AIDS, based on the research. So many older adults remain sexually active. Um, Usually they still having the ongoing sexuality even though they were older than 75. So some misconceptions persist between the older adults and are like saying they were no longer sexually active, which is a false belief that contribute to the neglect of sexual health education and preventing this from this population. So another study has indicated that older individuals who engage in sex more frequently gonna report higher levels of the happiness and satisfaction, also the less incidence of the chronic health conditions. So as you can see, this greatly impact the sexual well-being. Also, some other research has been shown like older adults are particularly vulnerable to the STI because as they aging, their immune system is declining. They came with some different multiple disabilities, comorbidities, and then they're taking many medications. So these patients are requiring careful management. So another study has also been showing that 87% of the older adults did not use the condom during their last sexual encounter. Also, they were engaging some high-risk behaviors, like paid sex, same-sex relations, and these are reflecting the lack of the awareness about the safe sex practice. And furthermore, the STI symptoms in the older adults are often mistaken for the normal signs of the aging, or mask some other medical comorbidities and polypharmacies, leading to the delayed diagnosis and treatment. So imagine if the baby boomer population getting increasing every year and then the lack of the education, this gonna be horrible in the end, like more older people gonna having sexual transmitted infections. Therefore, promoting an open communication, STI screening, sexual education is essential to maintaining the safe and fulfilling the sexual lives in the older adulthood. Next, we're gonna talk about how the age-related change and then sexual responses in elderly patients. So, as the aging, there's some common myths about older adults and the sex, including that the women gonna lose all the desire after menopause, men cannot get erections, older people are not interested in sex. These statements are totally false and represent the harmful stereotype that deny the older patient with the respect, privacy, dignity as sexual being, which can cause guilt, shame, isolation in the older adults. So, as we age, there are some natural biological changes that can affect the sexual functions. For example, the major change as we age is hormone imbalance. Like we talk about in the class, is a reduction of the estrogen for women, the testosterone for men. Um, so let's take a look on the female first. Menopause, this is the normal aging process. Is characteristic by permanent cessation of the menstruation for at least 12 consecutive months and marking the end of the women's reproductive years. So this is not a disease and is typically occurred between the late 40s and then early 50s. It's representing the transition from the reproductive to non-reproductive life. Some physiological change, um, as we said, decline in the estrogen, progesterone levels, since the ovaries stop responding to the FSH and then LH hormones. And estradiol also decreases to the body produce the weaker forms of the estrogen, which may causing different physical symptoms and also the mental system. Etiologies. So, besides the normal aging process of the hormone, Some surgical procedures like removal of the ovaries can also causing um menopause to appear earlier in life. Also, the medical menopause, like caused by the chemotherapy or radiation therapy, that can damage to the ovarian tissues. Um, some other things like lifestyle stressors, um, such as smoking heavily, having the poor diet, experiencing the chronic stress from the work or caregiving responsibilities, can also cause the menopause begin earlier. Some common signs and the symptoms. I pulled up this from the textbook, so you guys can take a look if you're interested. But I'm just gonna pointing out the most important one, which is a hot flashes, like sudden feeling of the heat, sweating, vaginal dryness, itching, pain during the intercourse. These are the important factors that could influence the sexual pleasures in women. Also, another thing is weight gain, gaining weight. Um, this can leading to the body image issues and having fatigue every day and decreased energies, emotional changes, um, like easy to get anxiety or difficulty concentrating on doing the task, having the memory problems or fuzzy thinking. So what are the diagnosis tests for detecting the menopause? Uh, Pretty easy, like we already said so far, like physiological levels. We can test it on FSH, LH, estradiol levels. These are hormone levels we're gonna monitor every year for as we getting old. Some other complications such as osteoporosis, this is gonna due to the decreased bone density and calcium loss, which can happen very commonly after menopause. And then we having the cardiovascular disease issues, um, vaginal infections, urinary problems, also the metabolic changes, like increasing the body fat, which can causing the overweight and slower metabolism, having more risks getting the diabetes. So some treatment. So on our textbook, it says hormone therapy treatment can relieve signs and symptoms of the menopause. However, this gonna only beneficial when it started before the age 60 or within the 10 years of the menopause. It also having the risk um percentage, like the patient gonna having chance to have blood clots, stroke, breast cancer after receiving this therapy. Um, but the doctor usually gonna consider the overall health condition that women has, like consider their age, consider other underlying health issues. So don't worry too much about that. And then on the research that I find, there are some other ways to prevent or relieve the signs and symptoms of the menopause as well, which including the lifestyle approaches, um, diet change, having the healthy meal plan, eating the food rich in phytoestrogens like soy, beans, whole grains, and they want to make sure they avoid the caffeine, alcohol, spicy food, which can worsening the hot flashes. Taking the supplement, calcium, vitamin D, magnesium to support the bone health to prevent those complications, and exercise, like walking and improving the mood, relieving the stress, promote the bone health and also the cardiovascular strength. Vaginal moisture and lubricants. This gonna relieve the dryness and discomfort, and the patient can buy those products from over the counter. It's gonna helpful during the sexual intercourse if the patient experiencing the symptoms that we discussed so far. And then relaxations, stress management, doing yoga, meditation, deep breathing, maintain the good sleeping patterns, and also the practice the hand hygiene, keep personal hygiene. These are also important too. So on the next slide, I put on the hypoactive sexual desire disorder. This is the common female sexual dysfunctions after the menopause. It characterized by the persistent lack of the interest in sexual activity that can cause the significant personal or relationship distress. The prevalence of the HSDD is about like approximately 8.9 women who aged 18 to 44 or 12.3% in women who aged 45 to 55 years old and older, and then the 7.4 percentage in women who aged 65 and older. Um, some other thing is the sexual dysfunction is more common in women than the men. We're gonna talk about this later on because it's having some physiological differences on the hormone changes. So the treatment for the HSDD is um the two medications I put on the slides, like bremelanotide and phenylbutyrate. This two type of the medication is FDA approved. But one thing to remember is these two medications only relieve the symptoms. They are not gonna cure the disorder. Therefore, as a nursing, we have to provide like comprehensive biopsychological approach, like providing the psychological support, counseling sessions, education the patient, communication, stress management, and self-esteem building. These are the essential for improving the overall quality of life in the women who was affected by the um STD. So we're moving on the biological change in men is called andropause. So in the textbook, the information about this change is this happened gradually, like age-related to decline of the testosterone production in the man, usually started around the age 30. So the physiological change, how this different compared to the women. The men gonna still continue to produce testosterone, but is at lower levels because testosterone gland gonna release more FSH and LH in the effort to stimulate the hormone production. However, the women is not gonna having this lower rate, probably because the annual pause in the male is happening around age 30, is kind of earlier. So the body gradually adapt to this change. So common signs and symptoms of the andropause including like reduced muscle mass, stamina, energy, erectile dysfunction we're gonna talk about later, and decreased libido, testosterone shrinkage, breast enlargement. Also is including the psychological factors, um, symptoms including the fatigue, depression, poor concentration, or memory problems. Some common complications is gonna increase the risk of the type 2 diabetes and chronic kidney disease. The diagnosis test kind of similar to the female is we're gonna monitor the hormone levels when they're getting old after 30s treatment. So the male also gonna getting the androgen replacement therapy. It's gonna improve the libido, mood, energy levels. The this therapy gonna having a risk factor like having the fluid retention, sleep apnea, breast tenderness, prostate enlargement. So it's really important to remember the therapy is contraindicated in the men who having the history of the prostate or the breast cancer. Also having the non-pharmacological management similar to the female as well. They're gonna having the exercise activity, health diet, maintain the adequate sleep patterns, stress reductions, manage existing chronic disease like diabetes, obesity, renal disease, and psychological support. Schedule the counseling sessions as needed to address the body image, low self-esteem, and the relationship issues. So, erectile dysfunction in the male after the andropause. This is inability to get or maintain a sufficient penile rigidity for sexual intercourse secondary to reduction in testosterone levels of the andropause. So the prevalence is reported that about 40% of the men between 40 and 70 years of age gonna experience some form of erectile dysfunction. Another research has been showing the prevalence of the erectile dysfunction increased from about 15% in the men aged above 40 to 59, and then to the 70% in the men who aged 70 above. Pharmacological therapy for the erectile dysfunction was including these three types of the medication, the PDE5 inhibitors. These are the common one. They're also providing the symptomatic relief, but they do not cure the underlying conditions. So, um, what should we know about other interventions is they also having the injections to increasing the local blood flow, but it's rare. The other thing is vacuum erection devices to mechanically draw the blood into the penis. Um, Some other thing to mention about right here is they also can using non-invasive interventions like lifestyle changes, psychological counselings to help relieving the signs and the symptoms. Challenging number four, the sexual well-being. Other risk factors we can consider in contributing to the sexuality and aging. Um, we're gonna talk about unavailability of the partner. So in the textbook, it says regular sexual partner. Oh, I'm sorry. Based on the research, it indicates that regular sexual partner diminished with age, like among individuals who aged 40 to 45, 79% reported having a consistent sexual partner, while percentage dropped into just 53% for those who aged 70 and older. This is important because usually the older man gonna marry with the younger woman and then is having the higher risk that man gonna pass away um first. So even though the partner it still exists, they may be too ill or disabled or institutionalized to remain the sexual active. As a result, the many older adults, particularly women, facing the emotional isolation and decreased sexual satisfaction due to the partner unavailabilities. Psychological cognitive impairment. Um, so the important thing right here is lack of the emotional intimacy. We haven't talked about this so far, but sexuality in the older adults extend beyond the physical intimacy. So it can also be involves love, affection, emotional connection, mutual care, like daily grooming, grooming the hair. Um, it means seeing beyond the physical signs of the aging to value the emotional closeness and warmth shared between the partners. So feeling desired and important to another person also enhance the security, comfort, also the emotional well-being. This is becomes especially meaningful in the older adults because they're usually facing various life changes and then losses. Um, social stigmatization, ageism, we already talked about this in previous lectures. This is gonna bring up to the negative attitude, losses confidence, withdrawal from the emotional intimacy. Anxiety performance. Um, this is also common, like For example, a, a man has lost his erection once during the intercourse, he will become more anxious that he may fall again on the next time. So this kind of anxiety gonna influence the performance in the future of sexual intercourse. Um, so this kind of the anxiety gonna replace the pleasure, reducing the desire and also the self-esteem. Body image concerns due to the hormone imbalance. This also gonna bring negative self-images, suppresses the desire and prevents the sexual connections. Um, Another thing to mention about right here is the culture factors. Like, a 70 years old woman who has been with the traditional value, feeling guilty about having the sex with her new partners because they are not married. Um, or just cannot accept the behaviors with another, even though the partner has been passed away. Um, so this kind of culture have been bring up to a long-standing gender roles, causing the anxiety, guilt, or insecurity, forming the new sexual relationships. Some other things we need to know is financial or legal concerns. Um, Financials can discourage emotional and sexual partnership. Some other things to mention here is misconceptions and myths. This kind of important because some misconceptions like the man gonna believe sex is unsafe after he's having heart attack, so he avoids the intimacy entirely. This is not true. If he talked to the doctor and doctor says it's okay to do so, he shouldn't worry about that too much. But because of the misconception exists in the society, and he was so scared, this kind of the myth gonna create unnecessary fear and avoidance of the sexual activities. So some other factors, including patient's medical conditions, like if they having the neurological conditions, stroke, diabetes, Alzheimer's, Parkinson disease, or other neuromuscular injuries, the body connections are essential for sexual function. So any damaging to this kind of leading to the issues with the arousal sensations. Um, Another chronic pain conditions such as arthritis or other musculoskeletal disorders can limit physical mobility and cause discomfort during the sexual activity and reducing the overall sexual satisfaction. And then we having cardiovascular conditions, the patients who's having the hypertension, dyslipidemia, or atherosclerosis. This gonna affect the blood flow and strongly associated with the ED dysfunctions or other sexual health issues. So this highlights the importance of doing a through medical evaluation when the patient get admitted into the hospital to identify the underlying causes and get realistic interventions in the futures. Um, Another common risk factor is medication risk adverse effect. As we studying for the pharmacology, we have learned that certain medications prescribed to the older adults can having adverse effects, either from drug to drug or drug to food interactions. They can having the sexual um function related um effect, like decreasing the potency, libido, or erections. Um, some common medication can causing those problems are the antidepressants, antihistamines, antihypertensives, or the certain diabetes drugs can significantly contribute to the sexual dysfunction. And as in nurses, we should review the medication whatever the new sexual dysfunction appears, checking any adverse effects could be from the medication the patient is taking right now, and then educate the patient about the side effects when those medication prescribed to the patient um, initially. And often we can asking the provider to consider the alternative drugs or the non-drug therapies when possible, like doing some non-invasive interventions are the best, like using the lifestyle changes, um, exercise, stress management, having the psychological counseling sessions, or talk to the social workers. So, opened up the communication can prevent the misunderstanding and supports the emotional well-being, also the treatment adherence. And then we have cognitive impairment. So, on our textbook, it says the sexual behaviors in the dementia can be challenging. Um, I think it can also be included like Alzheimer's because these are often more distressing from the caregivers and the family than for the affected person. Due to the cognitive impairment, the individual can display appropriate behaviors such as like taking off the clothes in public areas on the hallways, especially you can see in from the nursing facility. Also, some sexual comments or touching others, mistaking the caregivers or spouses for strangers, uh, misinterpreting the routine care like bathing, catheterization as sexual advances because they having cognitive impairment. So w- it is totally understandable they having these behaviors. Um, but this we have to know that actions are not intentional is resulting from the neurological changes and the confusion. So education reassurance helping the families and the staff to reduce the embarrassment, maintain dignity, and understanding that these behaviors are a normal part of the disease process, not deliver deliberate misconduct. Maybe we can direct the caregivers like guiding the person to the private area or having them um having the assessive personnel to assist them with the clothes changing, try to correct the behavior as we can. And then for the nursing care, we're almost finished. We're gonna having the nursing assessment at first, like collecting the subjective data, basically what patient says about intimacy, satisfaction, or the changes. Also the objective data, what we observe from the patient, like what kind of behavior, medications, physical finding, lab work they have. Also, we have to consider biological, psychological, and environmental factors, like their socioeconomic status, what are some stressful events they can encounter recently. And it's better to use the open-ended questions when collecting the data cues from sexualities because some patients they are um, embarrassed when talking or discussing those topics with healthcare personnels. So maybe we can ask them like, can you tell me how your health changes have affected your intimacy or sexual relationships? And if they're willing to talk to us, that would be the best. If not, we can using some other alternative ways to figure out what causes the underlying causes. Um, nursing diagnosis. So I put on three main diagnoses, like sexual dysfunction. This is due to the physiological change as evidenced by the decreased libido or arousal. Knowledge deficit, lack of the education as evidenced by the misconception that sex is unsafe at my age. And then the social isolation, loss of the partner, fear of the judgment, such as um, having bad body images, Um, what other factors can cause it? Um, they they are having the depressions or having cognitive deficits, other underlying health conditions, CVD or stroke can also having trouble to engage such sexual behaviors. So the ultimate goal in our textbook is the patient can express satisfaction with sexual functions. We're gonna use the SMART skill. We'll be learning from the first week of the class. The goal needs to be specific, measurable, achievable, realistic, and time time based. So short-term goal is the patient gonna verbalize understanding that sexual desire can continue with the aging. Um, express the feeling about body image or intimacy within 1 week after talking with the social worker or schedule with the psychological counseling sessions. In the long term, the patient gonna demonstrate the improved self-esteem and comfort with the sexual expression, or the patient will report an increased satisfaction with intimacy and emotional connections. Implementation. So on this page, we're gonna promote sexual health, dignity, education through the physical, emotional, educational, advocacy interventions based on what we're learning so far. Oops. So we're gonna assess and educate the patient, clarify any misconceptions, teaching them the normal sexual change with the aging, and refer them to the specialist if needed, having the regular examination checkup with the primary care doctors. Um, maintain the dignity, privacy, especially when the patients were in the nursing home. Um, having the door closed or close the curtain when we changing the clothes from the patients, and respect the patient's identity, use inclusive and respectful languages, even though they having different sexual orientation as our own. Physical barriers, lubricants, medication. These are some way to promote healthy sexual experience, and the patient also wants to avoid the alcohol and smoking because this can bring to the adverse effect if they taking the medications. Emotional intimacy, um, encourage like open communication with the partners, with the house workers, encourage non-sexual expressions, positive self-image, and body acceptance. We have to educate the patient that communication usually solve most of the problems. So if they having any questions about sexual dysfunctions, it's better to talk with the nurse or the provider earlier than later, so we can address those problems to prevent emotional depressions or anxieties. Advocate inclusive care facility policies, change ages and discriminatory attitudes, rise to the sexual expression and identities. So we're gonna follow the facility rules, and if there's anything about sexual violence or discriminations, inappropriate behaviors or languages, we're gonna report that and follow the chain of command. So finally, we have the healthy lifestyle, improve the appearance, self-esteem, um, balanced diet, exercise, mental wellness, overall emotional and physical health. This is so important because this is the non-invasive way the patient can relieve the signs and symptoms about the sexual dysfunction. They have to engage the healthier way rather than taking the medication or having the surgery done because those are bring the harmful effects to side effects to the body. Um, Lastly, we're gonna evaluate, and this is a continuous process. We're gonna continue to monitor how the patient doing, um, like the patient's the expected evaluation or outcomes will be the patient can demonstrate the both verbal and behavioral improvement, expressing the comfort, discussing the sexuality, showing the greater self-confidence and body acceptance, and exhibiting an accurate understanding of the sexual health and normal aging. The patient and the partner can communicate more openly and affectionately, applying the recommended interventions such as lubricant, exercise, or counseling to improve their existing issues. So, as a nurse, we have to evaluate these goals are better met, not met, partially met, and then so we can adjust the outcomes based on finding what causes, um, what are some process that we can improve, um, to having in, improve the overall health. So that'll be it. Thanks for watching, and hopefully you guys enjoy my lectures. And I put my reference at the very end of the page. I will also post some practice questions based on the lecture materials in the discussion on Canvas module.